Great. Thanks a lot for inviting me. I'm going to talk about anesthesia. I'm an anesthesiologist, so at Mass General Hospital, and I'm also in the Department of Neuroscience at MIT. And you might be wondering, why would you want to talk about anesthesia in a setting of psychiatry? Well, what I'm going to show you is that anesthesia turns out to be a phenomenon that affects a lot of brain circuits and alters these brain circuits. And through studying of anesthesia, we not only learn how we can take care of patients better in the operating room of patients requiring surgery, but we actually get some insights into how the brain works. And that's going to be a central theme. So these are my colleagues that I've had the good fortune to do this work with: Patrick Purdon from Mass General Hospital, and Nancy Coppell, who's back there. So any of the mathematics I get wrong, just ask Nancy, she'll correct me. Shion Ikeju, who's now our new department chair at Mass General. Ken Salt, anesthesiologist at Mass General. Laura Lewis, who is our PhD student, who's now at Boston University, also with Nancy. Marusa, she's a faculty member there. Marusa Naranjo, who's my colleague from Mérida in the Yucatan in Mexico. Miriam Sinechi, who is one of my PhD students, who's now at USC. Shinung Cheng, who is one of our postdocs, who's now at WashU. Ahmad Eskandar, neurosurgeon at Einstein now, and Sid Cash, neurologist at MGH. And these are the funding sources that we've had the good fortune to have over the last few years or so. All right, so this is the outline I'm going to follow. I'm going to give you a little clinical look at what anesthesia looks like. You know, what it is we actually do to patients to induce this state. Then we'll go into detail about Propofol, and from there I'll show you how you can make inferences about what happens with other drugs. We've studied pretty much most of the drugs in a fair amount of detail, both in humans, non-human primates, rodents, and also, thanks to Nancy, with modeling work. I'm going to show you what happens to the brain under anesthesia with aging. The dynamics change rather dramatically. Then a little look into some of the things in the future, controlling medical coma, and also the concept of reanimation, turning the brain back on, right? So these are the main points that I want to make. The first thing is that I don't know what concept you have of anesthesia, right now. Maybe you already know this if you heard some of us, talk before. But the brain isn't turned off under anesthesia. It's actually quite dynamic. And it's these dynamics that are responsible for creating the altered states of arousal. And we think that one of the primary ways to which the brain, the anesthetics generate states of altered arousal and consciousness is by generating oscillations, maintaining those oscillations, and they basically impede the ability of the various parts of the brain to communicate. I mean, that's basically the monarch nodes version of what I'm going to say today. Because of these oscillations are so strong, you can see them very easily on the EEG in patients under anesthesia. They change very systematically with age, as I suggested just a second ago, and they change very systematic with drug class. So there's a nice structure to them. And as a consequence, you can use this to actually monitor patients in a very reliable way using the EEG. And then one of the things that I'm going to talk about, as I said, I'm going to talk about turning the brain back on. Right now, we just sort of time how we let the drugs wear off. But one of the things that we see in kids between the age of 1 to 5 years of age wake up from anesthesia ballistic, about 25 to 30% of them. They're just, disoriented, delirious. In fact, it's a formal disorder. It's called emergence delirium. In older patients, and older you can be over 50 years of age. Depending on what study you look at, 40 to maybe 50% have some degree of brain dysfunction after anesthesia, which lasts for maybe a few hours, in some cases like several months, right? And we get some insights into why that might be occurring. But one of the ways maybe to help prevent that is to turn the brain back on. And you'll see why I'm suggesting that once you get a sense of how strong these dynamics are. All right, so let me just start with the definition. So what is general anesthesia? So it's this drug-induced state, reversible state that consists of antinociception, amnesia, unconsciousness, and akinesia. So antinociception is sort of like a technical term. I had put analgesia there before, but it's not analgesia, just to be precise. So nociception is the transmission through the body of signals that are typically harmful. If you're conscious and that happens, you interpret that as pain. So to interpret pain, you have to be conscious. But nociceptive harmful signals being transmitted through the body are called nociception. So if someone is unconscious under anesthesia, we want to maintain what we call anti-nociception. It's a technical point. And I started because when we wrote this review article in the New England Journal back 10 years ago, we didn't say it that cleanly. That's why I started here. So, but if you take these first four things here, right, so the amnesia, the unconsciousness, akinesia, you're not moving around while the surgeon's operating, these are all synonymous with death, all right? So that's why the reversible is important, right? All right. You don't pay me to knock you out, you pay me to bring you back, right? All right, all right. And then doing that by keeping control of the physiologic systems, all right? So here's basically how we do it. So a typical anesthetic, just a very basic anesthetic for just an appendectomy, you'll get at least 10 drugs, all right? So it's really polypharmacy. And just to give you some idea of that, so we might use a drug like Propofol to induce unconsciousness and then maintain it with a Propofol infusion, one of the inhaled drugs. The inhaled drugs are ethers. They're just derivatives of the ethers that were discovered as anesthetics back in the mid-1840s or so. And we still use them today. And we may use them in combination with other drugs, so opioids, as you might imagine, for analgesia to treat pain. We don't necessarily give you a drug specifically for amnesia. The idea is if you're unconscious, and hypnotics is just meaning propofol, the barbiturates. If you're unconscious, right, then you really can't form memories. And we'll see how we're going to infer that someone's unconscious. And we do give drugs which are paralytics, which actually paralyze the muscles or relax them, actually. It makes it easier for the surgeons to operate. And we give drugs to control hemodynamic stability as well as respiratory stability as needed. Right? So I'm just going to show you a video just to give you some sense of these dynamics. All right, so this is a lady I took care of a few years ago. She's about 60 years old. She weighs about 80 kilograms. And what I'm going to do is give her a bolus dose of Propofol. Just literally just push it in like this. And you're going to see what her EEG does. So she has EEG leads. So she has 4 leads. She has 2 here and 2 here. The ground and the reference are in the middle. And we're just going to watch her EEG dynamics. This is real time, it's not edited. Just to show you what happens here. All right? So the first thing you're going to see is it's going to become very noisy. See all this, a lot of high frequency noise is starting to occur there. And the reason that is she's doing this, she's tensing up. Because if you inject Propofol into a small vein, like the one on the back of my hand, it burns like crazy. So look at that, see that? That's her doing this, all right? That's actually going to be good for pedagogical purposes, because you're going to see exactly the second when the drugs take effect. Just give me about another 6 or 7 seconds here. So she's really like, we're saying like, bear with us, it does go away. Watch right here. Boom. See that? Beta oscillations. Now watch this, boom. Large slow oscillations. So right here, boom. Even deeper slow oscillation. She's out. She just went unconscious right there. Right? And it's going to get even deeper. It's going to go flat. And then burst, all right? And just totally flat, actually, all right? So that's typical. I mean, 60,000 people a day in the United States. This is an approximation like what's probably happening to a good fraction of them. So what did I just show you? So that was her awake, and the size of these oscillations matter. So they were about 5 microvolts here, and then she went to this state right here, the sedative state. So this is an important state to understand or get some intuition about, because that was that state where you saw it just come on just very regular, about 12 to 16 cycles per second, what we call a beta oscillation. Now, if I were taking care of her and I wanted for colonoscopy, where she just needs sedation, I would titrate my Propofol to that state. But she went right through it, with the large dose that I gave her. And the other reason this is important is that this is probably closer to the state that sleeping medications generate. Sleeping medications can't produce sleep. We'll talk a little bit more about this later, but this is sleep, REM, non-REM, REM, non-REM. All these drugs can do is create sedative states, hopefully from which then your brain's natural sleeping mechanisms will take over. They can't themselves produce sleep. So if you refer to sleeping medications, particularly those that are GABAergic, as weak anesthetics, that's actually a better description of what they're actually doing. They're sedatives, effectively, all right? Then you saw her go from here down to here. She skipped the state here. We'll come back to that. You saw the large slow oscillations, burst suppression, right? And then between the bursts, she was isoelectric. So these are states of coma. These are states that you'll see in comatose patients, and this is what the drugs are essentially doing. So this is one of the reasons why I feel very comfortable if I see states like this, and we'll say why neurophysiologically, that I know someone's unconscious under anesthesia. I don't have to worry about them being aware, right? And the final point I just want to make about these oscillations here is that look at the size. You see this is about 5 microvolts. Down to here it's about 20 to 50 microvolts. And the kids I'll show you in a bit, they can be as large as 1,000 microvolts, right? So what's happening here is that the anesthetics are hijacking the brain circuits and taking them over and causing them to oscillate in a very systematic way, right? So that you can start to get a sense of if you need to have oscillations like this in the gamma range in order to have normal cognition or what have you, I take you into a state like this and I hold you there, you can see why someone's going to be unconscious, all right? And to the extent that these are very different from this, I'll just say different for the moment, you can also see why as soon as you turn off the drugs, people are not just going to plop right back to their normal state, and these effects might persist for several days and in some cases even months, all right? So the way I'm going to show this is not as oscillations in the time domain, but mostly in the frequency domain here, because the spectral content of the signature of the drugs changes the function of drug class. And so I'm going to show you the time on this axis, frequency here, and the color code tells you the sort of the magnitude of the oscillations. So this is a classic illustration of propofol, all right, given over time. So this is a young woman I took care of a few years back. We give her a bolus of propofol here, just like I did with the woman there a second ago. And then here are the large slow oscillations. And then what you see occur is you see slow and delta oscillations from about 0.1 to about 4 hertz or so here, and then an alpha oscillation, something around 10 cycles per second, about 10 hertz or so. And so there are the slow oscillations there in the beginning. And you see here she has this pattern here. So it's like this. You have a slow delta oscillation like this, then riding on top of it is a higher frequency oscillation. And they're equally as strong. You can see them. You can tell by the spectral content. They're just as strong. So as long as I leave the infusion on, this is what she stays in this state. She's unconscious. I turn it off somewhere here. The oscillations dissipate, and she wakes up. All right. So that's how I'm going to show these Now, so there's a very rich temporal dynamic. There's also a very rich spatial dynamic, and actually it turns out that the expert in the spatial dynamics is sitting back there, Sujin Vijay, and he worked out a model for this, so you can ask him about. So this way, you don't have to talk to me. I'm pointing you to the experts on these topics here when those points come up. But we've done studies on patients, but also on volunteers. And one of the things that we do is we use whole head EEG, all right? We use whole head EEG. And so this is a gentleman that was one of our volunteers, and I'm showing you 44 sites on his head. So normally there's 64 in total, but I'm only showing you 44. And in each of the EEG sites, I'm showing you what the spectrogram looks like. This is before we start. So he's there lying like this with his eyes closed. Now, there's a phenomenon which is well known in neuroscience called eyes closed alpha oscillation. That is, if you were to close your eyes right now and we put electrodes here on your occiput in the back of your head, you would get a very regular 10 hertz oscillation, all right? And that's what he's doing now. So he's lying there with his eyes closed. And you see you can count 0, 10, 20, 0, 10, 20. It's here in the back. It's not in the front up here, all right? So he's got this eyes closed alpha oscillation. Now, what's going to happen is, as we give him increasing doses, we give him increasing doses of propofol like this, and we decrease them, this oscillation is going to move from the back up to the front. It's going to concentrate in the front and stay there. As long as we keep the oscillations going, it's going to basically stay there. When we turn it off, it's going to move backwards, all right? So not only is there a temporal dynamic, but there's actually a spatial dynamic across the head for these oscillations as well. And you'll see the drug doses here. And they're going to go up to about 5 levels. And each level, we're going to hold for about 14 minutes. So it takes about an hour to get up and an hour to come down. So I'll just play the video here. So you watch, it's going to disappear. So the drug starts now. So watch how it breaks up here in the back. Now you see that it's appearing in the front, and look how strong it is. And see, it's over this part of the head, right? The center of the head's here, and it's over there. And we're not even at the highest level yet, right? It's disappeared here in the back. Now watch what happens. As soon as we turn it off, we start backing it back. It's going to disappear in the front and reappear back here in the back. And he comes to. All right, so there's this. It's sort of like this, okay? All right. So I've shown you some phenomenology, all right? So we can draw pictures like this that actually start to talk about the circuitry. So I didn't say this before, but the way Propofol works, its actual targets in the brain are GABA receptors. So they're on inhibitory neurons, inhibitory interneurons. So it enhances inhibition. But as you saw, it doesn't just turn everything off until we get to a really large dose when it makes everything flat, because everything is interconnected. Just as one way of thinking about it, you have a system which is highly interconnected. You put in a stimulus which actually decreases some of the activity, and you find a mode of the system. So that's basically what we're doing. We're finding these very specific modes, and the modes that you find depend upon the types of drugs that you give. And they're targets for GABA here in the brainstem, here in the thalamus, up here in the cortex. So it's hitting all these sites simultaneously. We go to the OR, we see this. So this we can write down. This is what we see in the OR. And then I just showed you this. I showed you that this concentrates in the front of the head here. And the one thing that I didn't tell you is that when it concentrates in the front of the head, it's actually quite coherent. In other words, so if you take a site here and a site here, and you measure the correlation between those sites at the alpha frequency, the correlation is 0.8 or 0.9. Or sort of more generally, if you have like a spectral matrix like this, and you can do its eigen decomposition, and you take the ratio, of the largest eigenvalue to the sum of the eigenvalues here. There's 64 of them here. This ratio is 0.8 or 0.9. So there's one very dominant direction. So that's the dominant direction when the person is completely unconscious. It's towards the front of the head, basically. All right? So it looks like this. And so this is something that we deduced working with Nancy, that we think that this alpha oscillation is tying up the thalamus and the cortex. It's doing this, the 10 hertz oscillation. And just to remind you of a little bit of neuroanatomy, the thalamus is a major way station in the brain. It's almost sort of right in the center. So you have visual information coming through, you have auditory information coming through, sensory information, pain, as I mentioned before, comes through there. It helps modulate sort of motor control. So if you want to tie up one region, you can just put your finger on and tie that region up. This would be a good region to tie up to make someone unconscious. And so we think that part of the effect that we're seeing is essentially that. What's interesting about this, though, is the dynamics for the slow oscillation, the slow delta oscillation. Look, these guys are just as large here, but their dynamics are entirely different. The alpha oscillation is sitting there like this, totally coherent. Across the head, the slow oscillations are doing this. They're totally dephased across the entire brain, across the entire scalp, let's say, because we haven't recorded these entirely across the entire brain. Oh, that's not true, but in non-human primates we have, so I'll show you that in just a second. So, and this is part of that story. So here's what we think is going on with the slow oscillations. And here, I think this is the best evidence that I have coming from humans of what anesthetics are doing. So this is from Laura Lewis's PhD thesis. And Reed and I were just talking about this at breakfast. There are patients that have epilepsy, which is intractable. And so what they have, they failed all medical therapy, so they'll need surgery. So they come in, and the neurosurgeons implant electrodes in the areas where they think the seizure foci are. And what they do is they allow them to seize in the hospital off medications for like 5 to 7 days, and then they come back in and they remove the electrodes. And once they've identified the seizure focus, they'll do a resection, take that that aberrant part of brain tissue out. So this is somebody who had such an implantation. This is, as I said, this is from Laura's PhD thesis. So here are the neurons which are spiking, and these are the field potentials when the person is awake, and they correspond to these locations here on the scalp. And so if you look here, so here's what happens when the person's unconscious, right? And so here's what you have. Now when the person is conscious, and here when the person is unconscious, you have these large slow oscillations. And look, the neurons are spiking like, so this is a neuron. This is a neuron that's recorded next to this red electrode. So it can't spike wherever it wants to now. It can only spike now. It spikes now. It spikes now. And the same thing is happening. So here's another electrode, another neuron, which is only a few centimeters away. It's governed by this field potential. So this guy spikes here, this guy spikes here, this guy spikes here, this guy spikes here. With that sort of dynamic, it's going to be very difficult if you have to have coincident spiking to transmit information. It's going to be difficult to be conscious, all right? And to give you maybe a slightly more global look at this, this is work that we've just recently done with Earl Miller and also Jake Donahue. This is from Jake's PhD thesis, in which Jake implanted electrodes over, showing you 4 of the regions, but actually implanted them over 5 regions in the brain, including the thalamus. So the frontal eye field, so that's a frontal part of the brain, the ventrolateral prefrontal cortex here in the front, the posterior parietal cortex, and the superior temporal gyrus. And you can see, so this is under propofol again, you can see how the cortical dynamics are quite broken up. See these very long pauses in here, right? And we think these long pauses are probably causal in the sense that it's making, if you say what do we think is causing someone to be unconscious, it's these very long pauses that are occurring that are dictated by these slow oscillations, in addition to the fact that you have propofol tying up the thalamus and the cortex, all right? So why do I care about this, aside from being able to talk to an audience of mathematicians about it? Well, here's the thing, right? You go to a cocktail party, and no one goes, wow, you know those anesthesiologists, they're some really cool dudes, right? You know, they do all these sort of neat stuff, you know, they make it possible so you're nice and safe during anesthesia. You never hear about it. You hear about it when someone writes an article that says, wow, another case of someone being awake under anesthesia. In fact, literally, someone just called me earlier this week, Emery, I've been getting all these questions about awareness under anesthesia, what's up with that? All right, awareness under anesthesia is not a public health menace, okay? It happens 1 to 2 in about 10 to 20,000 cases, all right? All right, so the reason it happens is anesthesiologists aren't monitoring your brain. They use heart rate, blood pressure, movement to decide whether or not they're going to give you more drug. They're not using the EEG the way I'm talking about it here. And in fact, we have training programs at our hospital where we made it possible, like in the fall of 2018, for our colleagues to get an extra supplement in their paycheck if they did our online training. So 88% of the faculty did the online training. 23% of the anesthesiologists use the EEG in the operating. That's at our hospital, right? I mean, so we're there to help train, right? So, but it's given by rote. It's given by practice habits. So things like awareness, it's a solved problem in 2020. But if you ask why it occurs, with oscillations like these, even if either one of these is correct, it's going to be highly improbable that someone's conscious. Let me just say it that way. But you can see why it would persist. So these are what the drugs look like if you look at them in the time domain, right? But as soon as you flip them over to the frequency domain, you can see that the structure becomes a lot more apparent. I just showed you propofol. This is sevoflurane. These 2 drugs, even though this is an ether, a gas, and this is a IV anesthetic, they're roughly in the same drug class in the sense that they operate on GABA receptors, so they have very similar dynamics. But the ethers have this third oscillation that sits in here, the theta oscillation, which is something we're trying to sort out now. This is ketamine here. This is low-dose ketamine, right? With higher dose of ketamine, you'd actually see large slow oscillation. You probably heard a lot about ketamine being used to treat depression now. And this is the dosing range in which you give it to treat depression. And this is the dosing range where people would have, hallucinations. And here's dexmedetomidine. It produces just very profound, large slow oscillations. Right? And so just like I did for Propofol, we could go back and relate the dynamics that we see here to actually the circuits and have a very detailed discussion about why those things occur. And I put this in there just to remind me what I said earlier. General anesthesia is not sleep, right? When we meet patients, anesthesiologists will very frequently say to the patient, Mr. Jones, you're going to go off to sleep for your operation, because you can't go to them and say, Mr. Jones, I'm going to put you in a drug-induced reversible coma, but don't worry, I can wake you up, right? That's not a good way to endear yourself to your patients, right? So what I do is I just tell them what's going to happen. I say, you're going to be unconscious, you won't be able to form any memories, I'll be watching your physiology, your heart rate and blood pressure, I'll make sure you don't have any pain during the surgery or afterwards. I just give them the definition of general anesthesia, because there's no sense in trying to make it, because the metaphor isn't correct, it isn't sleep. And just to emphasize that, so this is sleep, as I was saying before. You go non-REM state, you go non-REM up to REM, non-REM up to REM. You do that about 4 or 5 times a night. The intervals are about 90 minutes or so. You typically wake up from REM, and while you have, during the night, you even have awakenings at this time. Anesthesia is this: I give you drugs, and I hold you in this state here in a fixed state. So the dynamics are quite different. And so there's no reason to think that substituting something which is a sedative or an anesthetic would allow you to have whatever normal, sort of the normal physiologic benefits that accrue from sleeping, right? So what happens as we age? So here is a person who's 30 years of age. So there's this Propofol. So there's the 10 hertz oscillation, there's the slow delta oscillation, right? And then here is someone who's 57. So this guy here could be this guy's dad. So you see he has a 10 hertz oscillation here, and the sort of the 0 to 4 hertz oscillation. Little less amplitude, but still quite strong, very visible. And the other thing I'm just going to point out, you see how this goes from about 10 to, let's say, 15, and this goes from about 8 to 12? That's a robust dynamic that we see. The range of the oscillation drops as we get older. And not only drops in amplitude, but the range drops as well, right? And then, now here's someone who's 81. So this is a woman I took care of who had a tumor on her chest the size of an American football. It took the surgeons the better part of 6.5 hours to remove it. And we were able to keep her, well anesthetized, just using actually 1/3 of the age-adjusted dose, because we could see the oscillations very clearly. They're lower amplitude, like right here, you can see them. And not only that, is that contributing to her being unconscious, but there's a complete absence of the rhythms that are up here in the cognitive band. And this is on a decibel scale, so so this is minus 25 dB up here, and this is about 0 dB, the way this is scaled here, right? So this is the part which is a little bit sobering. So these two guys are the same age, right? His EEG looks like his EEG looks like hers. We age different physically. It makes sense that our brains probably age differently at different rates too. What's wild about it is your anesthesiologist is the only person who can know that, or one who uses the EEG could know that, right? So, but it makes sense, and and we think that this may be, it probably does relate to the aging of the brain and maybe, sort of aberrant states. And so you can think about here, you can probably now guess what the kids are going to look like. So there's a 3-month-old and there's a 14-month-old, right? You can see there's the same dynamic across all the ages, but the power bands are much broader in the kids. And it turns out that the highest amount of power is up here, and the kids are about 6 to 8 years of age, So I know all you like 20-somethings out there, you're thinking, well, my brain is still robust. No, you're on the downhill slide too, right? The maximum was up here at 6 to 8 years of age, and you're trending downward just like the rest of us. So, hey, your time has passed. But anyway, if you look at the dynamics, you can basically see that it's the same dynamic, but it just has different frequency bands, or at least this representation shows that. So what are some of the things that we can do now that we know this? So I'm just going to say a couple of words about medical coma and about reanimation. So these are three very well-known people who had head injuries. And as a consequence of head injuries, they were placed in medical coma. So what is a medical coma? You actually understand it completely now. You give someone Propofol or one of the anesthetics, and you take them to a state of burst suppression, and you hold them there for several days, all right? And the idea in the case of someone that has intractable seizures is that this will eventually stop the seizures. Now, the ultimate therapy, in other words, for someone who comes in refractory epilepsy, if they can't stop in the emergency room with the standard drugs, they basically put them under general anesthesia and keep them for several days. And that's a medical coma. Or someone has a head injury and the brain swells during the injury, so you give them general anesthesia to allow the brain swelling to resolve, right? So if ever there were, so you're going to be in this state, or the patient's going to be in this state for several days. So if ever there were a time to use a control system, this would be it. So let the computer basically dose the drug over the 2 days or 3 days or whatever length of time the person is going to be in this state. So we worked out a system like this a few years ago with, we have our rat volunteers here. We have the EEG. And basically what you do is you record the EEG in real time. And burst suppression is very easy to see. We saw it when it occurred there. And you define something like the suppression probability. And so this is kind of like the fraction of time that the animal's in a suppressed state. So the way I've drawn this out here, if this is about a minute, if this is about a second or so, then 60% of this time the animal's suppressed. So I might target that. So I'll say, I want you to be 60% suppressed, all right? So that's the target. I'll measure and see what the actual suppression is, and I'll use the difference between where I want to be and where I am as input to the control system here to either increase or decrease the infusion rate of the pump. Just a very simple feedback control system, nothing complicated. So here's an illustration of it. So the EEG is up here. That's the target. We started at 0.4, so we want to be 40% suppressed. And then down here is what the pump is doing on a second-to-second basis. And so this is what the actual controller is actually able to achieve. This is the target it's supposed to achieve. So we're going to increase it. We're going to say go up to 0.7. So the controller goes up. And if you watch this, because 0.7 is now 70% suppressed, you're going to see the level of the EEG is going to drop down here. And the pump has different dynamics here in order to achieve this particular state. All right. And so what we'll do is we'll now raise it further, 0.9. And you see the pump dynamics are quite different. And see, compared to here, so this is 40%, 70%, and then this is now like 90% suppressed. So this is, it's totally tractable. And I've just shown you one example here. I showed you this guy here, which is animal 2, going up like that. But look at animal 4. See, animal 4, we went up, then we said, let's come down. So we started at 0.7, went up to, let's say, 0.9, and now come down to about 0.5 or so. So to come down, I don't have a drug that can decrease burst suppression. What the controller did is it just shut off. It shut off the pump. And then it allowed the blood levels to drop. The burst suppression decreases, and then it picks up again once it hits the level. So it's like a jet when it's going up, and it's a glider basically coming down. But this is totally feasible. So to get FDA approval of this, we've now been testing this in like non-human primates. And this is an illustration of some work that was just completed by one of my postdocs, Suresh Chakrabarty. And so he made a target level of 1, right? We can go into the details of how he got that. But 1, we know the animal is profoundly unconscious, right? And so what he did first, just to illustrate the difference between setting a rate, because what happens in the ICU or in the operating room, we just set the rates for long periods of time and look at them or what have you. It's not being updated on a second-to-second basis. So we're going to show you what happens if you just keep the rate constant. The ability for the ability to keep the target, to hold the target, compared with when the computer takes over. So that's a constant infusion right there. And so you can see it's kind of wandering up. It's sort of wandering down. And now Sarish is going to turn on the turn on the computer, let the computer control it. So now it's able to hold the target, much better, surprise, surprise, right, right? And then I think he drops it a little bit, yeah. And then he's going to raise it a little bit. Raise the target. And the computer can do that, obviously, no surprise. But again, simple idea not being used, but probably a better way to deliver the drugs, all right? So I want to leave you with one final thought. Like I said, one of the key things with anesthesia is waking people up. We don't give you any drugs to do that right now. I just want to show you some results from an experiment that was done by Ken Salt, one of my colleagues at Mass General, who's been working on this for a while. So this animal is anesthetized with propofol. And actually you can, when the words disappear here, see this IV here? This is white. It's a white IV going into his tail vein. Propofol is white. And he has an electrode which is sitting in his ventral tegmental area. So the ventral tegmental area is at the top of the brainstem. It's an important arousal center. It's important for cognition, all right? So what Ken is going to do is he's going to, in just a second, turn on stimulation and wake this animal up from anesthesia, all right? And you're going to see how awake he is, all right? So let me just play this. Maybe you won't see how awake he is. Okay, so you're not going to see how awake he is, but he was real awake. He's like super awake. So let me show you the punchline now. All right. So here's his cousin the next day, all right? So he's anesthetized with isoflurane, all right? And what's going to happen here is, so you might wake up, but are you functioning cognitively? Is your brain really back? So the animal has been trained to execute a task. He goes this way and hits the correct light with his nose, and then turns around, he gets a food reward. He's been trained to do that. Then we anesthetize him, or Ken anesthetizes him. And what he does is, he wakes up from the anesthesia when we stimulate the ventral tegmental area, and keeping the anesthesia on. We didn't turn the anesthesia off, we just waking him up by stimulating. And he goes, look, oh, I'm in the chamber, I'm going to go to work. So he goes to work and starts getting food rewards. Then what Ken is going to do is he's going to turn the stimulation off, and the animal's going to go right back out. He's only awake because the stimulation is overcoming the effects of the anesthetic. So watch him here. So he's going to turn the stimulation on. This is effectively what you would have seen in the other video. So he looks to, that's where the food is. So he looks to get food, but there's no free lunch. He has to work first. So he turns around, hits the button, then comes back, all right? Ken changed the stimulation down to 20 hertz from 40 hertz. He turns around, hits the button. He's wobbly, but he's actually executing a task. He's not just sort of there, dazed or what have you. And now what he's going to do is, I think he gets this one wrong. Yeah, that's wrong, so the light tells him that it's wrong. And he turns around again. And so now he's going to go back to try to work again. And Ken turns the stimulation off. And he's out. So he's only awake because we're actually stimulating this brain region. But he's actually awake to actually function cognitively. He's not just drowsy, all right? And so what's the anatomy of this? So the anatomy of this is the following. Here's that area called the ventral tegmental area. It's sitting in the midbrain, and it goes up to the cortex, so it's called the mesocortical pathway. And this is an important pathway for cognition. It goes through the limbic system, the hippocampus, maybe important short-term memory system, through the limbic system up to the cortex. And the primary neurotransmitter here is dopamine. And this is probably the principal pathway that's activated when you're giving Ritalin to kids that have ADHD. And in fact, people self-administer Ritalin to make their mind sharper. This is sort of well documented. It's not a very good thing to do, but people people do it. So, and we've actually tested this in the rats. Ritalin will have the same effect. It'll wake the animal up exactly the way the stimulation did. And so what Ken is doing is stimulating here. We showed you stimulating the VTA. We've also done it optogenetically to show that it's specifically the dopamine neurons that are responsible for this. So this might be one way to not only wake people up, but have them be cognitively intact after surgery. So this is what I've shown you, this empirical observation that the brain is dynamic. It's not turned off under anesthesia. We think that the oscillations are a primary mechanism. You can see the oscillations very readily in the EEG. They're quite systematic with anesthetic. They change with age. So this gives us a way to formulate a control strategy and also just monitor patients under anesthesia. I showed you something about actively turning the brain back on, why that might be plausible, how we might go about doing it. But I want to leave you with this, because this is the anesthesiologist's view of clinical neuroscience. We're here in the middle, and the rest of neuroscience rotates around us, sort of thing, But there are all these important contacts that we don't make because we don't take anesthesia seriously. We just think, knocking people out and bringing them back. And I've hinted at some of them, but I'll just go through a few here. So epilepsy. So at low doses, a drug like methotrexate, which is a barbiturate, can be used to create seizures. Or the alfentanil can create seizures. At higher doses, the methotrexate can actually be used to turn seizures off. All right. So we actually use it to create seizures in the operating room when the surgeon can't find the seizure focus. And you're all aware of ketamine. So ketamine is, has multiple uses. We use it to treat pain. In fact, if you're going to go to some remote area, you can only take one drug with you. You had to give anesthesia in a remote area, you would take ketamine, because it makes you unconscious as well, at high dose, makes you unconscious as well as it's a potent analgesic. It's been a model for schizophrenia for a number of years. And now it's a therapy for depression. And one of the enigmas that Nancy's going to talk a little bit about is, how can you give such a low dose of a drug and then have an effect that lasts for several weeks? Actually. And anesthesiologists shouldn't be surprised by that, because you anesthetize someone for several hours and then their brains don't work for several months and the drug is gone. So the fact that anesthetic effects can persist for extended periods of time after surgery is not surprising. Or just one other example here, locked-in syndrome, or Parkinson's disease. MPTP, the drug which is given to simulate Parkinson's, is actually a fentanyl. It's actually in the class of drugs like fentanyl. And it just turns out that it has such an affinity for the dopamine receptors, it actually just basically knocks out the dopamine system and creates a chemical Parkinson's disease. I mean, it was discovered back in the 60s, late 60s, early 70s, when drug addicts were trying to synthesize synthetic opioids in order to take them. And instead of getting MPPP, they got MPTP. And so again, but we use fentanyl all the time to take care of patients in the operating room. So, and then one final thought, the ideas that I was mentioning for turning the brain back on from anesthesia may be packaged in a way to maybe help patients recover from coma. Right? It's not implausible. And Brian Edlow, one of my colleagues at Mass General Hospital, is studying that right now. So all of these things here are, they touch an anesthesia in some way or another, but we don't appreciate the links if all we do is we think we knock people out and bring them back. If we think of it neuroscientifically, we can learn from what's going on in these other areas of neuroscience, and also they can contribute to help us develop better approaches to general anesthesia. So, thank you.